Okay, welcome everyone. Once again, we are here for a series of lectures that will be sponsored and provided by the East Texas Geriatric Education Center Consortium in partnership, as always, invaluably with the Texas AHEC East group. Just to give you an idea, this is today's agenda. There are lots of handouts, lots of information. I just want to spend 5 minutes going through some things that we need to go through, not only to introduce the speakers, but also to go through our continuing education instructions and what is required for that. But this is more or less what's going to happen. We'll have a couple of presentations, a short break, one more presentation, and then at the end have some time to fill out some evaluations. This series has 4 different sessions focusing on addressing difficult topics in aging and disease. I'd like to acknowledge the use of the input of our program planning committee to help put this together. It's been a great adventure trying to figure out the types of things that we want to try and do. February, we'll be looking at mental health disorders, mostly dementia and depression. In April, we'll be looking at cancer issues, screening, treatment, post-surgery, surveillance, and symptom end-of-life issues. And in May, modeling for long-term care, focusing on older prisoners and nursing home residents. These are learning objectives. They are listed, again, in your handouts. We have 8 of them, and it's going to cover quite a bit of material as an overview of aging and disease. We teleconference to 5 sites throughout East Texas as part of our consortium for the ETGEC, Lamar University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor, over in Waco, Victoria College in Victoria, and Weatherford College in Decatur. And we'll be bringing them on the screen. You'll see them when we have some discussion. We have ways of doing that. For CE, we offer CME credits, and all the paperwork is in the back there. Please make sure that you sign in. This is good for 3 hours. And there is an evaluation form, attendance record that you'll need to fill out, and then we'll mail you and send you a CME certificate if you're eligible for that. We also have CEUs for social workers. There's a sign-in sheet that you just need to take care of, fill out, and submit a registration form and a general evaluation form. For nursing, we have 3 hours nursing credits for RNs and LVNs. Again, there's a sign-in sheet. There's a form to fill out for your submission, and then we will be able to provide you with a certificate as you leave. So we have certificates already printed out. We'll put your name in, and you'll be done. Then you won't have to submit anything else. Okay? We have CEUs for physical therapists and occupational therapists. That's simply just filling out one of the evaluation forms. Let us know what you would like to receive, and that'll be also on the sign-in sheet. All right? Okay, any questions regarding what's required for the CE? All right, good.
Thank you all for coming this afternoon, and what we're going to be talking about is factors that impact the health of older adults. What I'm going to present today is a socio-ecological model for health of older adults and identify factors that influence their health as well as points of intervention using the model. We've had some great speakers this morning, or this afternoon I should say, and they've hit some of these things already about older adults, but I don't remember them talking in terms of socio-demographics, and I'm not going to go through too much. But just to tell you right now that older adults, and I'm using the age 65 years of age and older, okay, represent 12.4% of the population right now. And with the graying of America is expected to increase. By 2050, they're saying that there should be about 88.5 million from 35 million. So roughly maybe 1 in 5 people in 2050 will be an older adult of age 65 and older. We're also, again, following the trends of America, where it is becoming a more racially and ethnically diverse population. You can see here that older adults, at least 80% of them have at least one chronic illness. And again, looking at the slide, you see that they use more health care services and resources than those that under the age of 65. This is the model that we're going to be using. It comes from public health and it's used very widely. Health is recognized as a multidimensional phenomena, okay, that's influenced by numerous factors. This provides a framework where we can acknowledge that health is influenced by relationships between these factors at various levels, okay? So you can see that when we think in terms of healthcare and healthcare providers, very often we target the individual as being responsible for their health behaviors, correct? But we don't often recognize that there are other factors outside of their control. Once we send them home, a whole list of other things happen to them or influence their health. That's in terms of social support, community mediating structures such as neighborhoods, and public policies, okay? So we're going to go through each of the levels, and you're going to see again that they're very interrelated, where one factor will impact another one, and through the levels, okay? We're going to work on a case study, and I believe you have it in your packet. Is that correct, Tony? Okay. So take a look at it and think about it as we're going through the case study. And I also invite you and encourage you to think about the patients that you've had too. How does this relate to them? Or what other factors have you found that impacts their health? Okay. So you can see you're going to be Mrs. Martinez's primary health care provider. She is a 65-year-old Hispanic female living independently on a fixed income of $925. She's going to a senior citizen activity center when she falls down. A neighbor sees her, calls 911. She's taken to the hospital. The neighbor also calls her daughter. You can see at the end here that she's diagnosed with a right hip fracture that requires open reduction and replacement. So kind of keep those factors in mind. Okay. Now going through with the case study, you know that what happens when she goes home is going to depend partially on the discharge planning, okay, that you give to her. The plan that you develop where she's going home and what's going to happen there. If she goes home, she might go to a skilled facility, she might go to a nursing home, we don't know yet. And then the last part of the case study that we're going to look at is that she has surgery and rehab, and she is actually discharged to go live with her daughter and her daughter's family, which consists of the husband and 3 kids. Ages, I'm not sure, 3, 7, and 9 is good. Blue-collar workers, you can see that. And you come, our Mrs. Martinez is brought by her daughter at 1-month follow-up discharge to come to see you. And this is what you see from her, that she's alert, kind of slow in movement and response. She's appropriately groomed, her vital signs are within normal limits, and she has no post-surgical complications. She also has experienced a 6-pound weight loss. Okay, so just kind of keep those things in mind. What's influencing them? Now remember that I said the model has 4 levels. The first one is the intrapersonal or the individual level. Genetics, age, and ethnicity, of course, are not modifiable, okay? They're a given. Comorbidities and disabilities, remember we said about 80% of older adults have comorbidity, at least one. And the comorbidity or disability probably are modifiable, may or may not, depending on what the cause is. But the other ones that you see are very frequently associated with the health of older adults, okay? And keep in mind, there might be something else about Mrs. Martinez that I didn't mention, or maybe something about one of your patients that you might like to bring in. We're talking about economic insecurity or income insecurity. This is an economic loss of financial resources without an adequate safety net to replace them. That loss often results in a loss of basic needs, such as housing and food insecurity. Again, the interrelatedness of them. You can see that people that have economic insecurity very often have lower health and functional status, okay? And you can see where out of here that in terms of, they may spend more, about 20% of their spendable income on health care services that are not provided by Medicare. For example, Medicare does not pay for hearing aids, okay? I'm trying to think what else. I knew that before I got up here, but thank you. Dental, I like that. Thank you so much. In terms of the partial plates or the dentures or those kind of things, Medicare doesn't pay for it, and they are extremely expensive.
And minimal vision care.
Right. I think they pay for glasses maybe, or either that or just a vision, but it's very, very minimal, and you're going to get the very basic. And again, the okay, great. Okay, so the diapers and things are not paid for. So you can see where you're already spending, you have a limited amount, and there's going 20% of your income already. For seniors, the economic insecurity is usually associated with a lower educational level, which means a lower paying job, longer periods of unemployment, and lower insurance benefits many times, or lack of coverage. That in turn goes to the lifetime earnings that people have. They often have lower lifetime earnings, which means a lower retirement income. And again, thinking in terms of financial insecurity, health and disability cost. You can see again where they're taking a large portion of the expendable income. Oops, did I do this one right? Yeah. Housing is another one. If you go into the financial literature, have you ever bought a house, you'll know that they'll tell you that you shouldn't spend more than 21 to 30% of your salary on housing. And they very, very much stress that you go to the lower end, okay? Not the 30%. If you're paying 30% for housing, what's left over for all the other immediate needs that you need? It's a big chunk. Excuse me, it's a big chunk. The other thing very much so that I want to go down on this one here is on the neighborhood. Seniors very often describe their housing as being in a neighborhood. And the neighborhood, again, their definition varies from person to person. Their satisfaction with the neighborhood, though, is more in terms of proximity. Okay, the closer they are to banks and grocery stores, health and social services and resources, recreational, their social support, the more satisfied they are. Kind of makes sense when you think about it. Again, in terms of neighborhood, what they have a fear of is the neighborhood crime and violence. Think in terms of the elderly and how they are at increased risk for victimization due to their vulnerability. The other one that I'd like to point out is this. Does anyone know what this means, the Peter Pan housing? Okay. Think in terms of the housing market today. You have what? A home, a usual home, a regular home is about 3,000 square feet now? That's a lot of space for one or two people, especially in terms of keeping it clean, the maintenance and the upkeep, right? Think in terms of how they are built. Usually they're multi-level. Everybody likes those, 2-story, 3-story multi-level homes. Think in terms of the bathtubs now. Everyone wants a garden tub. Okay, how do you get in and out of it? Right? I don't use mine. It looks nice, but I'm not going to climb in and out. I might not make it. The other thing, too, is when you think in terms, do they actually have rails and bars, grip bars for getting in and out of the tub or sitting on the toilet? Those are extras. And they're not put in these houses now. They weren't put in back then. They cost money to buy and to have installed. Think in terms of the counter spaces. Everything is at a higher level in the cabinets. What happens when you have that limited range and mobility? Can you reach up high? If you're in a wheelchair, can you actually see the counter space? Can you go up and down the stairs? The point is that people are making homes now that are for the young, okay? They don't realize that people age in place. Once you grow older, your money and your ability to move become very limited. You may find yourself in a house that's insupportable and maybe even hazardous to your health as you grow older. Food insecurity is another one faced by many of the seniors. Food insecurity means that there is uncertainty or of not being able to obtain, or it's not available to obtain enough food for the household members. Again, it's usually due to money. You can see where it's associated with, I didn't put that on there, okay. It's associated too with lower health status with older adults. Think about in terms of nutrition. What do they eat? Can they go to the grocery store? Are they able to prepare a meal for themselves or not? All these factors come into play, and I don't think that we as healthcare providers always ask the right questions. The other thing too is if you have a limited amount of income, you need housing, right? You're paying for healthcare. How much is left over for utilities and food? One of the things associated with that is when there isn't enough money and there's food insecurity, is medications, where people decide to spend their money between food and between medications. So they might stop taking their medications. They may take it less often. They may take a partial tablet or a partial dose versus the whole thing, again, to make it last through the month until the next Social Security or retirement check comes in. What interventions can you have for the food insecurity? Again, I come from a public and community health background. What do you know about your communities? Are there food banks?
We have 2 Meals on Wheels programs available to Galveston Island residents.
Right, yeah. Galveston is one of the few that actually has a Meals on Wheels, okay? What about SNAP, the Supplemental Nutritional Assistance Program, the food stamps? These are things that are within our responsibility in our area of being able to address. And again, as I go through these things, sometimes I know as healthcare providers, we have a very limited amount of time to address these issues. My suggestion is that you select one person on the unit or the office that can go out and do a community assessment, find out what are the resources that are available in terms of housing and food and whatever else, transportation, any of these needs that your patients are going to need. If you can't take care of it, at least you can provide them with some informational brochures or maybe have someone talk to them about it. Transportation is another very big one for the seniors, okay? Transportation is associated with an increased quality of life for individuals. Can you think of why? Independence, exactly. You can come and go as you please. You can go to the places you need to go, as well as some of the places you want to go. Your social networks and your recreational activities are just as important as going to the bank, going to the grocery store, going to the pharmacy. Unfortunately, there comes a time when we get older that our eyesight becomes impaired, our depth perception perhaps, our hearing. We might not be able to hear that ambulance, that EMS coming behind us so we can get out of the way, right? Our reflexes get slower, so we may fail to stop or turn in time. You can see how these are going to affect the safety. And a lot of the times when we see our clients, we don't stop to think of how they got there. Case in point is one of the clients that I've had in the past. She didn't often keep her appointments, and we're getting frustrated with her because she doesn't show. Well, you know, we didn't take into consideration at that time that she's an older woman with COPD and arthritis, plus a couple of other things, and she's on oxygen therapy. And yes, she has a little oxygen portable thing that you roll around, but it's what, 10, 12 pounds? Okay, and she's a frail elderly, and she's got arthritis, and we're expecting her to walk 3 blocks to the nearest bus station, which we didn't know that she had to walk. Puts a whole different spin on adherence, okay? The other ones that we see are those that are driving that probably should not. At least the state of Texas now, at a certain age, they made you go and take a vision test, and you have to pass it to get your license, okay? But again, it might be, these things might occur before that vision is tested by the state. Again, if you can't turn your neck to see back or forth, you're going to have a problem. If you can't hear, you're going to have a problem. So start to ask them, do you have a valid driver's license? Anyone ever stop to ask them? Probably not, right? You just know that they came and that's good enough. But think in terms of traffic violations, and have they had accidents? And what about any hospitalizations related to those accidents? You can see where all of a sudden that independence is going to be have to wait about the safety of themselves and others. This is not easy to do, and I can tell you from experience, I have had patients, and even my own father, who didn't talk to me for a while, but he wasn't safe driving. One of the things that one of the patients found that I remember was she was a grandparent, and it was when one of the grandparents ran over her own grandchild in the back and didn't see her that it really hit home that that's why I shouldn't be driving. I can't see. So we try to get it to stop before that happens. Depression is another big one. And sometimes there's a stereotype or a thought that depression is part of normal aging. It's not. Yes, it's okay to be sad about about a loss and to grieve, but when the depression is persistent and it is impacting adversely on your ability to function in life, something needs to be done. Depression is associated with suicides in the elderly. I don't think I put that, yeah, I did, about 16%, okay? It's also associated with lower health status and poorer health outcomes. You can see in community dwelling adults about 1 to 5% experience depression. You can see when they're homebound, They're very limited. They have a loss of independence that it jumps up to 13.5%. In terms of hospital patients, 11.5%. And again, there's another 5 million that are not diagnosed because they don't meet all the criteria. You know, if you're in a hospital, you're in home health care, get a psychiatric consultation. Depression is treatable with antidepressants, psychotherapy, and preferably both. You know, sometimes these questions are hard for us to ask, and what I've looked is for some of the evidence-based, using some assessment questions. There's lots of them in the literature if you go and take a look. I tried to get the ones that are more succinct and to the point, will identify a problem so you can do a further follow-up, okay? Substance abuse is another that's often found in older adults. But somehow or other, we sometimes fail to address it like we do in younger adults. And again, it is more important perhaps in older adults when you think in terms of the illnesses that they have, the functional disabilities, and as well as many of the prescription medications. It's not a good mix to have alcohol with some of those other medications that they take, and you set them up for an adverse reaction, okay? The other part that's problematic is, again, only 4%, when you're going back to national studies, only about 4% of older adults receive education, counseling, and treatment. You know, I think the perception sometimes is that they don't have an alcohol or substance abuse problem. Substance abuse is associated with depression. Now, did the depression start the substance abuse or the substance abuse start the depression? Don't know, but both need to be addressed. Again, just a questionnaire to use, CAGE. It's a very well-known assessment questionnaire, very easy to administer. If you get a yes on one of these, you might have a problem and you need to follow up, okay? Health literacy. Have you ever thought about health literacy? It's the ability to read, process, and understand the health information that's given to you so that you can make an informed decision about your health care decisions, okay? Older adults and those that are non-English speaking are more at risk to have experience health literacy. And it's needed, it's necessary. How do you read the information that we give you when we send you home? How do you navigate the healthcare system if you can't read? How do you fill out those complex forms that we have? Can you read them? Can you understand them? Think in terms, it also has a numeracy skill attached to it, numbers. You know, do you need to interpret those blood glucose levels when you're doing your self-monitoring? You need to be able to measure your medications. What if we're telling them to look in terms of nutritional information on canned goods or whatever they're buying and they can't understand that the numbers don't mean a thing to them? So those are things we need to look at. Unfortunately, there's a lot of shame and embarrassment associated with health literacy. One of the ways to intervene for this then is to make it a general statement that I read this information to all my clients. You're not stigmatizing, you're taking it away from them. They know that other people experience this as well too. Some of the assessment cues that I wanted to talk about is one of the things you really don't know, but you can observe what's going on. They may pick up the brochure and like this one up here is have it upside down and they're reading it, okay? Well, that's a cue for you that something's not right here. Or they'll tell you, I'll read it later when I get home, or I forgot my glasses, I can't read it now. One of the ways to overcome this is to do what we call demonstration, return demonstration. Read the information to them, then have them talk back to you to describe what it is what you told them, okay? How are they supposed to take their medications? How are they supposed to do their dressings? How are they supposed to administer their insulin? You read it to them, you show it to them, you have them describe it back, or you have them demonstrate it back, okay? And I think one more. Okay. So we just kind of finished with the individual. That was a real quick and dirty, but it got the information across. Can you think of any other factors that you've experienced in your clients on an individual level that's fairly common? Okay. Right, that's a great suggestion. I don't, since he didn't have the mic, what our audience member was saying was that he has the family member there, especially in the first meeting, and that they bring all the medications together to look them over whether they're taking them or not. In psych in the old days, we used to call that brown bagging. I don't know if they have a new name for it, but you know, we'd have them bring in everything to look at it and to tell us what it was for and how they took it. So that's a great example of it. Thank you for sharing. So now we're going to go to the relationship level. These are a couple of the ones that are more common, again. And again, think in terms of Mrs. Martinez, is there something you need to know or like to know, or maybe your own patients. Social support, social isolation, and loneliness are three concepts that are very related, but they're not similar. Social support includes the real or perceived resources provided by others that enable a person to feel cared for, okay? And you can say the more social support you have, the better the health or the health outcomes, the health status. There are two types of social support. One is tangible, like in terms of physical assistance, actually helping them with their daily activities, as well as an emotional component, helping them to be cared for and valued. Social isolation, again, is being removed from other people, more or less. For example, those that live alone and don't have anyone to interact with, or those that live in geographically rural areas, okay, where there's not a lot of people around. And loneliness, again, is being or feeling apart from others, being different and separated. All of these, again, contribute to the health and the well-being of an individual. The more social support you have, the lower the social isolation and the loneliness, the better the health outcomes. How would you do social support? What could you do? Or think in terms of Mrs. Martinez, maybe. Where was her social support? Yeah, the senior center activity. Okay. Still in terms of relationship, we're looking at the marital and the caregiver status. It's important to know who your client is living with. Is it with a spouse? And what is the health condition of that spouse? Are there any physical impairments? Are there any kind of illnesses? And who's taking care of them? Maybe the client, or him or her, I should say. I'm not trying to be sexist here. But who's taking care of the spouse, and at what level of commitment does it take? Think in terms of perhaps a frail older woman who has a husky husband who's maybe 6 foot something, about 190 pounds, and she needs to turn him and bathe him and everything. It's a lot of hardship, a lot of physical activity that she may or may not be able to do. The trend now too is that grandparents, especially grandmothers, are taking care of their grandchildren. Okay, now they're taking on a responsibility after they've already raised their own children. And again, if they don't take care of their children, who do they go to? Maybe a foster home, maybe to somewhere else again. But they're having to take these responsibilities on of either spouses or children, and they're doing it at a sacrifice to their own physical and mental and sometimes financial health. And again, do we often ask about this? Things to ask, things to know. Elder abuse is another big one that you can see. Okay. It's found in all communities among all strata. It hits everyone. It occurs in every race, religion, creed, socioeconomic status, whatever you want to say. And again, it's acts of omission or commission, things that are actually done or not, intentional or unintentional. Can be in terms of physical, psychological, sexual, and financial exploitation. Some of the common signs and symptoms of abuse are delays in seeking medical care, having an incongruency between the history of illness or injury between the client or your patient and the person that brought them in, perhaps the perpetrator themselves, poor hygiene, malnutrition, being underweight, dehydrated. Those are some of the signs and symptoms that you need to see. So what do you need to do? You need to screen and assess every older person and every time, okay? Things change from visit to visit. Now, having said this, I'd like to tell you about a personal experience I had with my own mother several weeks ago. She was hospitalized for pneumonia, and I'm sitting right next to her bedside during the triage, okay, where they're doing the intake. And she is asked, "Are you afraid of any member of your home?" And I'm thinking, wow, that's great. They're assessing for elder abuse. And then I'm stopping and I'm thinking, and if I were a perpetrator, what would that do, right? If you are asking someone about this when their family member or their friend or whoever is sitting next is a potential perpetrator, are you really going to get an honest response? I don't think so. The other part of that is you place that person at risk for violence and abuse by asking that question. So yes, you're going to assess each and every time, but you're going to assess in private, okay? All right, so now we're going to community level. Were there any questions about the relationship ones? Yeah, I didn't mention that, but that's great, unsafe environment for them. And yes, sometimes we find that very difficult and frustrating to work with elder abuse cases. And often the client or the patient is not very happy with the outcome, okay? It's not satisfied. Many times it requires a change in living arrangements or caretakers. And again, change is very difficult for most of us. And as you age, sometimes it becomes more difficult. The unfamiliarity really has an impact. You're so used to a routine and your surroundings, it's easier for you to navigate and everything else. Take you out of your comfort zone, you experience stress. Thank you, that's a good one too. So now we're going to talk about community and neighborhood characteristics. The social and the physical conditions or the neighborhood characteristics of older adults can impede or enhance their health in various different ways. And again, these are a couple of them. I'm going to start with housing. Think in terms of the housing. We already talked about the Peter Pan housing, okay? Think in terms of prices of housing or the rentals. Again, many older adults do not own their home like they used to in the old days, okay? What are the conditions of the home? Think in terms perhaps also of the neighborhood. Is there a lot of crime? Are they in close proximity to the grocery store, the health and social services they need, the recreational activities? Can they walk to it? Are they on bus lines? And again, we're going to cross into public transportation as well, okay? So where they live is very important, and their satisfaction with the living arrangement very much goes with the neighborhood characteristics. When you think in terms of public transportation, is it easily accessible? I just gave you an example where it wasn't. Thinking in terms of money, how much does it cost? Okay. Public transportation, I'm trying to think too. Think in terms of, you know, we have older adults and we tell them that they need to exercise to be healthy. Okay, then we're going to send them out to a neighborhood with a high crime rate. And what about if there are sidewalks? Can they walk on the sidewalks? Are there sidewalks? Are they in good repair? Or are we asking them to walk on the street in a busy intersection or a busy street? Again, what we tell them and what the reality of their living quarters or their living environment always aren't conducive to good health. The other thing that I like to talk about is the health and social services. Are there healthcare providers, clinics, hospitals within easy proximity to them? Are they on a public line, public transportation line? Okay. And what about in terms of reimbursement for some of these? Do they have money? Will they be taken care of? Yes, we're supposed to give them in the emergency room care. We stabilize them and then ship them out to somewhere else, right? Who if there's no insurance? Medicare also says that you can only spend X amount of days before you're discharged for whatever forever illness. So again, are you healthy enough to be discharged or not? And again, with the reimbursement for Medicare being so low, there are healthcare providers that are turning patients from Medicare away. They prefer the private pay patients. And again, I brought in the culturally competent workforce as well too. Think in terms of the cultural diversity that we have now. When they go to the clinic, when they go to the hospital or the healthcare providers, is the staff only English speaking? Are there translators available? Okay. What about the information that we give them? Is it in English in whatever dominant language of the community is spoken? And what about those forms too? And I think cultural diversity, I'm putting healthcare in there. Do they have 12 font, for goodness sake? I can't see 12 font anymore. I need 14 or 16 so I can read it. But think in terms of being elderly and having these kind of impairments and what we're asking them to do. Have any other questions on this one or not? Any other ideas? That's great. Yeah, having a cell phone on someone versus the, what I think, medical alert? Is that where you punch the little button? Okay. Yeah.
This way you have
Direct and a faster response. Great going. Yeah, thank you. See? Good. Okay, the last part of the model then is more on the societal. You see ageism there, and that's discrimination based on perceived or actual chronological age, okay? And ageism is associated with the social-cultural context. We all have assumptions and perceptions of what it is to be old, okay? Think in terms of your mass media. If you look at it, everyone 65 in age, 65 years of age and older are constipated and need a Metamucil, right? Are they having incontinence and they need Depends? Can you think of any positives? Maybe Viagra, thinking that people, well, no, seriously, people are human sexual beings, right? Intimacy is part of that. So I think I'd reframe that and say that's maybe a positive being in knowledge. But when you think in terms of it, for the most part, it's not very positive. They make growing old not a good thing. And it can be if, again, we take care of health on an individual basis for all of our clients and look at all of their needs that they have, okay? The other thing, too, with ageism is that we can buy into it as both individuals and professionals. You ever had a client that say, oh, I'm too old for that, I can't do that, okay? Think in terms of some of the treatments, okay? They might think they might not be able to take the side effects, or they're afraid to because of their health. So they limit their options of treatment to improve their quality of life, to improve their quality of health. Think in terms of ourselves as professionals sometimes too. Do we think in terms of age and say, oh, that chemotherapy is not going to be good for them, okay? And again, you have to take a look at the individual, their age, their lifestyles, their quality of life, a lot of factors. But the point is that before we take out a treatment, we need to see and validate it on the assessment. Is it a valid reason to reject it or is it not? There has to be a good reason for it, not just based on an assumption, not just based on a stereotype that we have. And I think that is, anything else y'all can think of on a societal level? Oh, I forgot the public policies and health policies. Those can be positive or those can be negative. Think in terms of Social Security, okay? That is now one of the largest sources of retirement income for older adults, right? So that's a positive in a sense. Medicare is another positive, right? They now are assured health care, at least a level of health care. But the health policies sometimes have regulations and rules. There's eligibility criteria. You might have to have a certain income to qualify. You might have to be a certain age. Well, what happens in that interim before you meet that criteria? What are you going to do? Think in terms of how we provide care a lot of the times too. What are the criteria that we admit people in, that we send them to services or let them be eligible for services? So when we're sending our clients home or our patients home, and we're thinking that he or her is responsible for their own behavior, their own health, we need to consider the larger context. They may not have everything under control to take care of themselves. Any questions or comments? Okay. So what about question number 3? Where are the points of intervention that you could do? What could you address the issues that we found? Right, screen for depression, exactly, okay? And if it's positive, then we do some kind of treatment, either antidepressants, psychotherapy, or preferably both. Good one. What else? Home visits? Yeah, home visits, good. Sign her up for that. Caretaker as well, too, for herself. All right. Right, see if there's a senior activity, and for many of them, they do have an actual pickup and delivery if you're in a community that can do that. That would be wonderful for her. What else can you do? Yeah, ask about the relationship with the family. How are things going? What can be different? And there are things when she talks about the family relationship, you may look for things such as housing vouchers for her or maybe an assisted facility living. You might have the family put in food stamps as well too, okay? So those are some of the kind of things. Or public transportation, or not public transportation, I'm thinking some of the shuttles or vans that actually pick up seniors and take them to their appointments and things of that nature. So there's a lot of things that we could do to help points of influence or points of intervention. Again, is identify the factor that's influencing, and then you can work on it. And from a socio-ecological perspective, what are the societal factors that influence your perception of her and your care? Did you have any? How do you perceive her as an individual before or after?
Well, she's an elderly woman who broke her hip.
And there are things associated with that.
And she could be dead in 12 months.
Okay, and we may react according to that, whether we want to or not. It is an assumption of perception, false or not, but we may act upon that. What else? She's independent, yeah. And that might be something that we don't think about, and now we have her totally non-independent perhaps, or with a lot of a loss or limited autonomy, self-autonomy. Okay, great, thank you. Anyone else? Right, and what activities does she miss? What can we do to support that or to enhance that for her? So there's a lot of things that we often don't look at. And again, I picked some of the more current ones, but as you can see, people came up with different ideas and about factors that influence. And I strongly encourage you to take a look at your patient and look at them as an individual and find out what's important to them. Just because you do an assessment for what you know to be on that checklist, there are other factors that need to be addressed, and you need to explore it and identify it before you can even start to address them. So anything else? Any other questions? Right, taking like a home health assessment. Those scatter rugs that Dr. Goodwin talked about, when I do a home health assessment, those are the first things that go. It's so easy to trip on. And you know, it does just cost a few dollars perhaps to put a bath bar when you're going in and out of the shower to help you. We have some of the clients that have had burns when they're cooked. They're still able to cook, but their reflexes or eye perception is buying them those, what do you call them, those kitchen mitts that are high, so when they go to get something out of the oven. There's a lot of things. We just have to identify the problem first before we can address it. So that was all I have for today. Any questions or concerns? No? Well then, thank you for this afternoon's presentation, and thank you for helping me out with the audience participation.